despite the match which is coming, I'm going to make sure that we will finish on time. I'm going to talk about the acute rhinosinusitis complications and also the update on the management. So my talk will be divided into 3 parts. Firstly, we will define current management and define the acute rhinosinusitis. Then we're going to talk a bit about the recurrent acute rhinosinusitis, and then lastly the complications and the treatment. So in the first place, I think we should talk or define the acute rhinosinusitis. So on the right side of the screen, you can see that this is the definition by EPOS guidelines, and acute rhinosinusitis is defined as an onset of 2+ symptoms for less than 12 weeks, sudden onset, very important, nasal congestion, obstruction, nasal discharge, blockage, plus/minus facial pain, pressure, or plus/minus reduction or loss of smell. In kids, we tend to rely more on objective symptoms or objective measurements because obviously the history taken can be somewhat limited. So you'll be looking for obstruction, congestion, obviously, and then discolored discharge and presence of cough. In terms of pathophysiology, I will just very quickly explain what we understand so far. So in a patient with the acute rhinosinusitis, which usually starts as a typical cold, which is caused by a virus, or it can be precipitated by allergy, coexistent allergy. What happens is that there is a swelling in the area of the opening of the sinuses, which then leads to mucosal congestion, and as a result, there is increased production of the fluid, which is the result of irritation. The secretions at this moment are not, this is not a bacterial infection, but what happens subsequently is the reduction of the ventilation, there is drop of oxygen, increase in nitrates, which is perfect environment for bacterial superinfection. And so then bacteria will start to grow, and this will turn into bacterial acute rhinosinusitis. And so then you can see that we can perform some interventions. Either this will just go away spontaneously because the body can resolve, can treat this very effectively, or we can help with antibiotics, saline douches, and so on. And we will talk about that. In terms of the management, so there are quite a lot of high-quality studies, randomized clinical trials, and these 3 treatments are at the moment recommended based on the evidence. So analgesia, paracetamol, and ibuprofen, that's really about improving the quality of life and decreasing the symptoms and making the sinusitis more bearable. Intranasal decongestants for maximum of 1 week. The rationale behind is that we're trying to keep the openings of maxillary sinuses and other sinuses patent, keep the oxygen flowing, and prevent bacterial superinfection. And then saline douches. So a randomized clinical trial, several randomized clinical trials showed that this is beneficial for the course of disease, and we recommend more frequent douching up to 4 times a day. If the symptoms last longer, then after 7 days, we recommend high-dose intranasal corticosteroids until resolution of symptoms. And there are certain situations where antibiotics are indicated. And these situations are if there is acute bacterial sinusitis or if there are significant comorbidities, then we would recommend amoxicillin for 7 days or phenoxy, methylpenicillin for 7 days, or if there is allergy, doxycycline. If there is no improvement after 48 hours, treatment should be coamoxiclav or azithromycin in case of allergy to penicillin again. And so in terms of recognition of symptoms that are typical for bacterial superinfection, we would be looking for discolored discharge, severe local pain. When it comes to discolored discharge, really purulent, smelly discharge, green discharge, or yellow discharge. Yellow discharge is typical for infiltration of leukocytes rather than any microbes. And then obviously fever above 38, elevated CRP, and double sickening, which means deterioration after initial maldephase. And in terms of comorbidities, we would be interested in the presence of significant coexistent heart disease, lung, renal, liver, or neuromuscular disease, immunosuppression, and then especially cystic fibrosis. Now, what is not recommended, and this is again based on high quality studies, randomized clinical trials, steam inhalation. Steam inhalation can actually cause damage because if the temperature is too high, we can cause a damage to the lining mucosa within the sinuses and nasal cavity. Then oral corticosteroids do not seem to make a difference. Antihistamines, unless there is coexistent allergic rhinitis, and mucolytics. So that was about the acute rhinosinusitis management. And then we have got entity which is called recurrent acute rhinosinusitis. First of all, we receive a lot of patients with a suspicion for recurrent acute rhinosinusitis, but remember, up to 90% of patients will have a diagnosis of migraine or neurological type of pain. So it's very important to differentiate between these two entities. A true recurrent acute rhinosinusitis is an episode of 4 to 6 episodes of ARS in lasting for 4 weeks, with a asymptomatic episode in the between. I like my patients to come into the office during the episode so we can look inside of the nose, ideally perform the CT scan and CRP or full blood cell count. If we will establish the diagnosis, so the CT scan will have positive findings of inflammation, opacification within sinuses, or on flexible nasal endoscopy, there will be purulent discharge and swelling and typical picture of rhinosinusitis. Then we want to firstly treat the patients with intranasal corticosteroids. And if we decide to go for a surgery, we need, of course, the CT scan. What I would like to mention, and is not on this slide, is that we also should always investigate whether the patient doesn't have coexistent allergies, because patients with allergies are prone to have more frequently infections than general population. So, and especially, for example, dust allergy, which can cause problems all year round. So investigations of allergies is also very important. We've learned from a couple of papers that patients who have recurrent acute rhinosinusitis are more likely to have a higher prevalence of anatomical abnormalities or anatomical variations like concabulosa, accessory ostia, or infraorbital ethmoid cells. So that's what we will be looking at on the CT scan. And if we decide to go for a surgery, the aim of the surgery would be to improve the ventilation of maxillary sinuses especially, and open up the hiatus semillunaris. And the main aim is really to keep the ventilation, oxygen flowing whilst there is this initial phase of just a standard cold, so it will not turn into bacterial acute rhinosinusitis. And so then surgical steps would include maxillary antrostomy and bilateral anterior ethmoidectomy, specifically removing of the bulla ethmoidalis. And so in terms of differential diagnosis, as I mentioned, allergic rhinitis, chronic sinusitis, all the neurological type of headaches, otitis media, eustachian tube dysfunction, and then obviously just a common cold. In terms of the current evidence, these are the papers that are currently out there. So there is an evidence, although we do not have any proper randomized clinical trials, but the evidence says that the patients do have a significant improvement if they are well indicated for the surgery, and patients had fast minimally invasive sinus surgery. We can see there is patients tend to have 50% less or fewer infections than before the surgical interventions. Now, I'm going to continue with the complications of acute rhinosinusitis. So we have got the three main categories: orbital, intracranial, and bony. The orbital ones are the most common, so I think this is the most important to recognize and understand the management. First of all, I would like to emphasize that it seems from the evidence that antibiotics do not reduce the frequency or incidence of complications. So by not giving the antibiotics, the patient is not more likely to have the complicated course. So one of the papers compared incidence of complications of acute rhinosinusitis in Netherlands and then in France. In Netherlands, you are very, very unlikely to be prescribed antibiotics. And in France, pretty much everyone will leave the GP practice with antibiotics. It's a bit of exaggeration, but the difference is really dramatic in terms of prescription rate. But there is no difference in a complications rate. And so this is one of the few studies which is pointing towards antibiotics not being that important factor. When it comes to these, so I'm going to talk now about the orbital complications. Important is that obviously orbita is close to the ethmoidal sinuses, which are most commonly affected. Then orbital septum is the only tissue barrier. And the most importantly, there are these valvulus superior and inferior ophthalmic veins, which can let the infection to spread direction towards the orbita and also intracranial. The most susceptible group are the kids who are younger than 7 years of age, and usually we see isolated orbital complications. And actually that second point should be more than 7 years, obviously, where we see orbital and intracranial complications. So in older than 7 years old patients, we would see abscesses that are also affecting other sites like intracranial. We use this general criteria to describe the type of complication. I will just very quickly run through that because it's most of you know it, and it's not necessary that important for this particular talk. So we have got the preceptocellulitis, which is the most common type of complication. It's an infection of the part which is anterior to the septum, which is standing in between the soft tissues of the face and the intra-orbital components. And we would then see the eyelid edema, but eye movements intact. There will be normal vision, and CT scan will show diffuse edema of the eyelid and conjunctiva. So the lid and conjunctiva is affected, intra-orbital components are not. Then orbital cellulitis, that's the type of infection complication where the infection spread already towards the orbital, intraorbital contents, and we would be looking at eyelid edema, erythema, proptosis, chemosis, limited eye movements, vision sometimes is impaired, and as you can see, this intracorneal space can be affected. And then CT scan will confirm that intracorneal components to be inflamed. And subperiosteal abscess, in the CT scan will show this typical pattern of a collection that is located subperiostally. Very often there might be only the beginning of abscess, but once there is fully developed one, you would see the rim enhancing hypodensity with a mass effect. And patients will often present with the proptosis, chemosis, sometimes even ophthalmoplegia, and vision can be impaired. all depends on the position of the abscess. If it is more posterior, patients will be more likely to develop deterioration of the vision. If the abscess is anterior located, obviously there will be less overpressure on the eye components, and patients will have less of a symptoms. Then we have got orbital abscess, which is the abscess within the intraorbital space. Now this is severe complication, which really will present, patients will present with a severe exophthalmal schemosis, ophthalmoplegia, visual impairment, and CT scan will show hypointense mass within the conus. And then lastly, we have got cavernous sinus thrombosis. We would be looking for orbital pain, proptosis, chemosis, ophthalmoplegia, but symptoms also very often are in the contralateral eye, and there will be, and this is the major difference, associated sepsis and meningism. So you would like to investigate the signs for meningitis, but if the patient has got any sign of complication, orbital complication, you would always want to explore and examine signs of meningitis. And then, of course, the CT scan will show some signs, but definitely MRI scan will be indicated if the CT scan will show any suspicion, and there will be signs of meningitis. In terms of treatment strategy for the subperiosteal abscess, in terms of treatment strategy, at the moment, the ENT UK guidance clearly states that every subperiosteal abscess should be treated surgically. So should be always drained. Whether there are different ways how to treat that, I will then explain it later. But if I can maybe show on the CT scan how it looks like. So if you can see on the CT scan, there is on the left side, here is only swelling and inflammation of soft tissues, not necessarily already formation of the abscess. You cannot see any rim, and it's a enhancing structure. In the middle, you can clearly see that there is enhancing rim, and there is abscess collection, and this is subperiosteal. And then on the right side, you can see MRI scan, which is showing the abscess, but this is intraorbital abscess and not subperiosteal abscess. So obviously, the location is completely different. It is intraconal, and it is not close in the proximity of the periosteum. And important is also the size of the abscess, size and position. As I mentioned before, the ones which are located posteriorly are more likely to cause crowding in the space around the optic nerve. The ones which are located very anteriorly will cause very little symptoms. I would like to just point out on this last paper, which is a systematic review by Smith. And in the systematic review, it was nicely shown that patients who are of age 9 years old and older, and there is proptosis, there is restriction of eye movements and elevated pressure at presentations, that these patients should be treated surgically. And if the patients will not fulfill these criteria, there is a role for to wait and give a patient antibiotics for 48 hours with a frequent eye examination. In terms of treating the abscess, so there are many ways how to skin the cat. Obviously, we have got endoscopy approach and then external approaches. Lynch incision is the most common type of approach where you would treat the medial positioned abscess. But then we have got also transcaruncular, transconjunctival, which are rarely used. But when it comes to the lateral position abscess, then obviously the Lynch incision wouldn't be sufficient. We would have to go for the, for example, lateral blepharoplasty incision, as you can see on the picture, where you would be able to access the lateral compartment of the eye. Now, in terms of choosing the right approach, the most important is to save the eye and not to be a hero, if you can put it this way. So if you are comfortable with the external approach and Lynch incision is what you've been trained and you're not a rhinologist, then definitely go for Lynch incision, because it is about the vision, and by not treating it properly, it can have a catastrophic outcome. So the Lynch incision, as you all know, is what usually ENT surgeons are trained in. If you're rhinologist and you have a good experience with the endoscopic approach, this might be feasible. But remember, we had in the past quite some patients where this hasn't been done properly and vision was affected. Usually, the major problem was that the surgeon trained or opened up a bulla ethmoidalis, and there was a purulent discharge coming from the bulla, and surgeon thought that actually the abscess has been drained, because the field is very swollen and bleeding during the acute phase, and unfortunately it wasn't drained properly, and then it led to long-term problems with the vision. So this is the case one. So this is a 21 years old patient who developed swelling of the lateral part of the right orbita, and now despite antibiotic treatments there was worsening, which led to ophthalmoplegia, proptosis and visual impairment, after which the CT scan has been done, and clearly this is for surgical treatment without any doubts. So this patient needed a lateral blepharoplasty incision in this case, which allowed really the access into the lateral part of the orbita and draining of the abscess. So the incision is in the, as you can see, it's a blepharoplasty incision in this crease, so it's not also aesthetically feasible. Then afterwards you expose the rim. There is important is to perform incision and cut on the periosteum, so you need to get into subperiosteal space in order to prevent any damage to oculomotor muscles and contents of the orbita. And then afterwards, by dissecting in that space, you will easily get into the area you need to. Now, in most of abscesses, you don't need to perform such a lateral incision. This is mainly for decompression of orbita for Graves. You can easily end up maybe somewhere at the level of the lateral canthus. Now, this is another patient, which is a boy, 8 years old. Again, reduced eye movements, proptosis, but no visual deterioration. So there is clearly an enhancing rim on the CT scan. And so we concluded there is abscess. And this patient, again, needed drainage, which has been, in this case, done endoscopically with a very good result. I can maybe slightly move to further part, just so we can, we'll have a time for all the complications. So now I'm going to talk about the intracranial complications of acute rhinosinusitis. Question is how to treat this entity, because there is a lot of discussion about that. There is not necessarily consensus paper which would clearly shed light into that, and the treatment varies really from hospital to hospital and department to department. So important is to understand that the spread is hematogenous, most commonly, and not direct. So the most type of area where the intracranial collection is in the frontotemporal area, which is not adjacent to the frontal sinus. So the infection spreads through the diploic veins that are valvulous and that allow they flow into corticalis, and they allow the infection to spread in the ascendant way. And so because there is usually not a direct spread, there is a role for the medical treatment rather than to open the sinuses at the same time as we drain the intracranial collection. In cases of direct spread, where we can see that, for example, there is a pyocele or underlying sinonasal abnormality, where there is, for example, thinning of the bone and the abscess is on the other side, obviously that's a different situation, and we should consider also cleaning and draining of sinuses. But the vast majority of patients, the sinus anatomy will be normal. There will be sign of acute rhinosinusitis, and patients would deny having any previous history of chronic rhinosinusitis or having polyps or any other long-standing problems. In terms of treating them, at the same time, what is important is that neurosurgeons at the moment would not necessarily drain collections that are smaller than 1 centimeter, and would very often decide to go for medical treatment. If that is the case, then we would definitely not drain the sinuses. If surgeons would decide to go for surgical treatments of the intracranial collection, then obviously that's the patient where we would consider whether sinonasal surgical treatment is needed. And so this is the algorithm that we follow at Guy's Hospital. So obviously there is a patient who is admitted with the intracranial complication. And if there is a collection, then we would usually go in the first place for medical treatment of the acute rhinosinusitis, regardless whether the patient will go for neurosurgical drainage or not. In terms of conservative treatments, we would, of course, go for nasal, prescribe or recommend nasal decongestion with xylometazoline, then Nilmet, saline irrigation, and obviously IV antibiotics. Now, there is this exception box which describes the situations where we would treat acute or sinonasal abnormality pathology surgically. And so this would be persistent fever after 48 hours of IV antibiotics with complete opacification of sinuses, then the reaccumulation of intracranial collection after the drainage, any signs of expansive pyomucoceles, so there will be clear bony expansion, not just opacified sinus, and then of course there is no drainage pathway, or sinus disease with the bony dehiscence and evidence of spread intracranial cavities I mentioned before, or cranial neuropathy with sphenoiditis. Sphenoiditis is usually one of the reasons why we would treat it surgically. And in that case, we should consider sinonasal surgical treatment. So there are quite a few ways how to treat especially frontal sinusitis. In terms of standard FAS, anatomy is, in most of patients, there is normal anatomy, and if you perform the FAS, you will not preserve the anatomy. It will be very tricky. FAS would be simple for maxillary washout, but not for frontal sinus drainage in the acute inflammation. Balloon sinuplasty, that is one of the reasonable approaches. So anatomy is preserved after this. There is a very low complication rate, fairly simple to do, but obviously the problem is that you might not end up in a correct place, which means in the frontal sinus, and it's difficult to confirm that. Remember, even when you open the frontal sinus, there is in most cases you will not find much of a pus. You will not definitely find as much pus as you are anticipating from the CT scan. Then decongestion of smaller mucosa. So this is a approach that, for example, Professor Stamberger used to do in Graz, and also what I would try in the first place in my patients. So this approach needs a lot of patience. So usually after intubation of the patients, you will insert neuropathy with adrenaline into the frontal sinus and slowly decongest the frontal recess. And because we anticipate that there is normal anatomy, the frontal sinus should at a certain moment drain, and it should be able to nicely decongest it and potentially also wash it out. This can be always combined with the balloon sinuplasty, but simply just decongestion very often is sufficient. I have often done it also in a local anesthesia at the bedside. And an open approach is very efficient. Highest success rate, of course, is we're talking about trephination. You completely preserve the anatomy, so you will very unlikely cause any problems for the future. You just need a step incision, so aesthetically there is not really much of a problem. And when I perform the trephination, I would firstly drill a hole, of course. Then important is to make sure that when you enter the sinus, you will also cut the mucosa, which is on the anterior table, because very often if you insert a blunt instrument, you can pull and pull the mucosa off from frontal table, and for example then do not enter the frontal sinus and end up in this submuco periosteal space. So once you safely enter the frontal sinus, and you can confirm it by flushing out or aspirating some pus, then I tend to firstly decongest the frontal sinus with the xylometazoline, and so then you will decongest the frontal recess from the top, and then afterwards we can wash out the frontal sinus very efficiently, and you will see in most of patients that saline will start to flow into the nasal cavity. And so we have got here now some cases where you can see that there is this is 14 years old who had a typical presentation associated with the intracranial collection. So signs of meningism. CT scan showed opacification of the frontal sinus, and then extra axial area of the fluid collection concerning for the subdural abscess. What we've done is the craniotomy and decongestion of frontal recess plus minus balloons sinuplasty. Actually, we did use the balloon, and so we have nicely dilated the frontal recess and managed to drain the contents of the frontal sinus without any significant damage to the anatomy. Also important is to understand the pathogens. The odontogenic type of pathogens, like for example Streptococcus mieleri, in the patients who are usually adult patients, older patients, on the CT scan you will very often see some odontogenic or dental changes and maxillary sinus infection related to some translucency around the roots of the molars. These are more aggressive type of infections. In these patients, you would have I tend to have a lower threshold to go for surgical treatments, because very often we would cultivate Streptococcus mieleri, and patients are more likely to, with the Streptococcus mieleri, develop multiple abscesses, not just one. And in conclusions, we have to really appreciate that 95% of the acute rhinosinusitis patients, or the etiology is viral infection, and there is no need for antibiotics. The antibiotics do not seem to prevent serious complications. And in terms of the recurrent acute rhinosinusitis, it seems that if this is well indicated, it may improve the quality of life and frequency of infections. But again, we have to take into consideration possibility of neurological headaches, which are extremely common. Then complications of odontogenic sinusitis in adults have worse prognosis, and we have to be vigilant and really look for the odontogenic cause. And when it comes to treatment or orbital complications, there is now a trend in a major centers all around the world that we do not always have to rush into surgical treatment and have to really carefully look for, of course, the symptoms, have a proper ophthalmologic examination, properly assess the CT scan, and really look for clear signs of abscess, because very often this can be a bit confusing. Thank you for your attention.
Thank you. Can you hear me?
Yeah.
Excellent. There's a few questions in the chat, so thank you very much. That was a lovely talk and very succinct and right on time. So first question, if complicated sinusitis with laminar papyracea erosion, would you allow the patient to sniff their nose or do a nasal wash under pressure?
So that's a good question. So I think that in the first place, why there is a erosion of laminar papyracea. So if there is erosion of laminar papyracea is usually surgical complication. Any other erosion of laminar papyracea would be fully healed, so there will be no communication with the intraorbital components. If you cause a breach during the surgery, it then fully heals, of course, in a post-operative course. And if the patient will later on develop a problem, then I can't see a reason why, if you will blow the nose, there will be any emphysema.
And how long would you wait for the sort of healing to occur post-op if there was a breach?
I don't think there is any clear answer for that. Now, if, for example, there will be known breach and the patient will have a black eye after the surgery, bruising, possible any emphysema, then obviously, if it will be 3 days after the surgery, I would definitely be very cautious about blowing the nose. You can wash the nose with the irrigation without blowing the nose, so you can just passively let it flow. That's what I would recommend.
Next question, why would you not recommend mucolytics in acute rhinosinusitis? 2 people have asked this question.
Simply because the well-done randomized clinical trials showed no difference between the placebo. So that's really they make sense, obviously. Before these studies, of course, you might consider that, but the evidence is quite strong and do not seem to make any difference when it comes to acute rhinosinusitis.
Thank you. Next question. If one has to be cautious with oral corticosteroids in acute rhinosinusitis, at what stage, if at all, are they indicated before proceeding to surgical treatment?
Of acute rhinosinusitis. So that would be very rare. We would not really treat the acute rhinosinusitis without complication. This was pretty much always go away on its own. If there would be complication, that would be the reason. If there is any precipitating factor, like for example, some previous surgery which would lead to stenosis of the maxillary sinus opening or odontogenic sinusitis, and the patient will have more complicated cause that would not resolve after a couple of weeks, this might be the reason. But we would normally not really go for surgery.
And a follow-on from that for a different person's question, would you recommend oral steroids in the case of orbital complications?
So that's a good question. There is no clear answer for that. There are some studies by ophthalmologists which suggest that it might be reasonable. So my answer is there is no clear indication for that, but also there are studies which suggest that it might be reasonable. So I would not give it in the first place, but I know that many experts are now becoming to give corticosteroids, and I think in the near future it might be one of the recommendations.
Thank you. How would you manage odontogenic sinusitis? I'm assuming this is complicated odontogenic sinusitis will you refer this patient to MAC-SACS immediately?
So the odontogenic sinusitis is very important, the treatment. So at the moment, we have established a consensus. There was a very good paper by Professor Hopkins and the rest of the guys' team, which determines that odontogenic sinusitis in the first place should be treated by dental team, because in more than 80% of patients, this will lead to resolution of symptoms. And the remaining patients, the remaining percentage, we would then treat with the combined in the second stage with the sinus surgery. So there was a trend to treat all the patients with the odontogenic sinusitis, firstly endoscopically and then sent to dentists. But yes, there is a very good evidence that this would lead to very quick resolution of symptoms, improvement, but patients still need to have a dental treatment. And since the dental treatment is needed either way, and most of patients will improve, even though it will take a little bit longer, but they will improve, we would avoid 2 surgeries, and it will make it logistically much easier. So the recommendation is to send patients firstly for dental treatment, and then if needed, to consider sinus surgery.
What's your comment on the use of concurrent nasal wash and topical intranasal steroids for acute rhinosinusitis?
So the xylometazoline is stronger, essentially. So we would recommend definitely xylometazoline. Simply the level of decongestion is more significant, and topical corticosteroids would be for the subacute phase, following 7 to 10 days after the start, when you would stop the xylometazoline. And in terms of whether to place them into the, you can either combine it into the nasal wash or separately. I have to emphasize that in UK, diluting nasal drops into the saline douches is off-label use, and the pharmacists will probably struggle with that.
Do you send a microbiology swab in acute rhinosinusitis? And if so, does it change your management?
If I would see odontogenic sinusitis and patient would have a complicated cause, which means intracranial complications, then very often we would do yes. Because presence of, for example, Streptococcus miller, would change the management. We would be more, the threshold for the surgery will be lower. Even though, of course, that's not necessarily the reason to decide for a surgery, because these are acute patients that would come to A&E, and you need to do something straight ahead.
Another person's question: does the balloon sinuplasty really help in the long run?
No, I mean the balloon sinuplasty is really only for the washout to allow the frontal sinus to drain. I would say that we perform these less and less, and we are way more conservative. So as you could see, that flow chart, that's the most recent consensus that we agreed on, and so you can see that in this flow chart, the medical treatment is what we would go for.
Thank you. Couple more. Do you recommend, no, we've done that one. Role of decradone in acute rhinosinusitis?
No, so we would not recommend it, no.
Not sure I understand this question, but if Andrew can clarify, is subperiosteal abscess plus postseptal orbital abscess ? I'm not quite sure. So if Andrew can clarify that question, that would be great. Have you found fungus causing acute rhinosinusitis?
Yes, we have. So we had an pretty much necrotizing fasciitis, which was caused by invasive fungal disease. Yes, this can occur. It is extremely rare, but obviously there was one case a couple of years ago when it was very difficult to open the eye, and this is what I didn't mention during the presentation. And there was essentially delay of the ophthalmology assessment, and then later on it was it became clear that the patient has got severe post-septal, so the intra-orbital inflammation, infection, complication that was actually in the end caused by fungus. And important is that the ophthalmology assessment, you don't have